Okay, so I think I feel still asleep today. So okay, let's let's share the case first. So topics, we go to the last days. Yeah. Chat. Chat. I think I need to share the screen first. Okay, here we go. Okay. And then chat. That's the case. So then I can also share. I hope you can see my screen now. Can you?
Yep, we can see it.
Okay, cool. And I suppose you can hear me as well.
Yes.
Yep.
Cool. So this case, I think I made up the age because I wasn't sure about, in my records I don't have the age, but it looks like a middle-aged dog. And then it's a terrier cross, acute lethargy, and I think I should have put some degree of dyspnea as well. All of these very acute, and these are the radiograms. Okay, so as usual, we just go through all the findings. So there is a left lateral, right lateral. Okay, there we go. Left. Okay. Computer. Okay, there we go. Okay. Thoracic set, 3 projections, right, left, and DV. Okay, and I'm all ears. So again, you can rely on my, what I'm showing, or you can just click on that link, and then you can open the images in your computer and then be able to manipulate and everything. I think probably both are useful because if you want to tell us something about what you think, you may be able to draw. So if you share, so you do as you want.
Pressure sort of on all fronts. He says he would not buy it at all. NAV is his least favorite of the big 4 banks. The profits are gone.
Okay. Okay, so I'm all ears. We go first findings, and then we try to explain them. We see if we can get to an agreement where we all agree on what is actually, what are the changes, and then we try to put them together. We try to explain them, basically. That's probably the way to say it, to make a story out of the findings.
Mariano, did you post the link in the chat to the images?
Yes.
Oh, I can't see.
Okay, I can do it again. So
Thank you.
Okay, here. So this is the chat, and then that's the link. I should be there.
Thank you.
So normal or abnormal?
Abnormal.
This one is, I think, a bit easier, and it's clearly abnormal. Probably the challenge is going to be trying to define. Last time we talked for a little while about, if we can at least, first is if it's normal or abnormal, and then second, to localize, where is the abnormality sitting anatomically? And then kind of the luxury would be to then bring that to the list of differentials. So in that journey, sometimes the last bit is first impossible, and sometimes the last bit is the most difficult one, and usually the least certain. But trying to localize, trying to first decide if it's normal or abnormal, and then try to localize that, I think it can be done relatively easy in most of cases, not all of them. So probably this is the challenge in this case. Can we localize where the abnormality is sitting? But don't go directly there. Just tell me, the radiographic features, kind of a description of what is wrong.
Well, it looks to me like you've got a pleural effusion because you've got obliteration of the features in the chest. It seems to be bilateral. You've got leafing of the lung lobes and you can see the leafing in the dorsal areas of the caudal thorax. On the left side, I can't quite decide whether you've got a bit of air in there as well. On the left lateral aspect. The heart doesn't appear elevated because the trachea is not elevated, so I don't think the heart's enlarged, but you can't see the heart clearly. That's about list of all I can see at the moment.
Okay, I will leave it there, just to see if someone else picks that up and agrees or disagrees or challenges it. Or I have a little bit of a challenge, but I will not step up and leave everyone to bring their findings first. Anything else? It's just like all pleural effusion.
I don't know if I'm making this up, but the lungs just look more white than I would expect for the degree of pleural effusion that's there. And particularly, I don't know if the DV labeled the wrong way around, but the side that's not labeled left in the sort of caudal lung lobe, you can't really see the edges of the, oh yeah, there you go. So the right caudal lung lobe, you can't really see the edges of that lung lobe up against the ribs. I can't really figure out where that is.
Okay, good. So then you're adding to the whole picture that there may be some primary lung changes, or
Yes.
lung changes, and then you're saying they're basically or mostly in the right lung. Is that correct?
No, I think it's generalized, but the right caudal lobe, I just can't see that at all on the DV. So I'm not quite sure why.
Okay, good.
I think you
I'm
also
stating the obvious, and someone may have stated it before. I've sort of been keeping an eye on a kid in the background, but loss of cardiac silhouette, it's pretty obvious, but important to state.
Good.
there's on the right lateral, you can see the left cranial lobe delineated from the left caudal lobe. So I think there's some difference in the lung density. Also on the left lateral, you get an outline of possibly the right. I don't know which lobe it is, but there is lobar sign there as well, differentiating a couple of lung lobes in the cranial chest on the left lateral. And I think that dorsally on the laterals, you've got this differentiation between some lung density that makes it, I just can't, saying with what Jill said, I can't see why, I'm not sure why you have both a pleural effusion visible, but then you also have an area of lower lung density that's probably actually normal lung density adjacent to a higher density lung that I'm not sure what the pathology is there that's causing that. I don't think it's a pneumothorax because you can see the outline of the lungs because of the effusion.
Okay. So I suppose you are talking about these lines, like that one there. Can you see my arrow?
Yeah, that's what I.
So that one, and I suppose that one. And then, so what would be your conclusion out of that line? Like if I know that you identify it, and then I understand that you went back and forth, or you are thinking aloud, which is absolutely cool, about what it could be. And I think the considerations were, if that's pleural effusion, if that is pneumothorax, okay, have I captured what you were trying to say? So first, that is abnormal. First, that you are not certain where or what it is, and then the considerations are pleural effusion or pneumothorax. Am I correct there?
Yeah, but when you look on the DV, I'm not sure, is it a DV or V? I think it's a DV on the left side, left caudal area. So you can see lung, there's just a differentiation in the density of the lung here to here. And I don't think it's pneumothorax because you can see the outline of the lung away from the ribs, which I think means it's a pleural effusion. And I don't think you have pneumothorax, but you just have a change in the density of the lung quite laterally on the left side. On the right side, the lung is denser on the caudal lung, and yeah, I guess there's differentiation.
Probably a way. Let me. It probably is not needed. Probably I'm bringing more confusion, but let me bring a sentence about this. So it looks like there is a line there that you don't expect. Then one consideration will be pneumothorax. However, pneumothorax is unlikely because in the other projection, actually you see the border of the lung that is separated from the wall, and there is something soft tissue outside. So then that will never happen in a situation of pneumothorax. Makes sense? You will not have soft tissue outside, you have gas outside. And if it will be a combination of fluid and gas, basically you will get a level line, not a level line in a lateral, in a projection like this, but it would look different. And then I would add two more arguments to believe that not to challenge that line, I think that line is abnormal, but to challenge the idea of that being pneumothorax. One argument is a relatively weak argument, and is that we can see vessels going across. So the reason why I'm saying, so why that's an argument, because then if it's pneumothorax, then no vessel should go through. And the reason why that's a weak argument is because we have two lungs. So then it could be the one lung is retracted and then the other lung, then the vessels are still going across. So then that's a dangerous feature that I'm using. Right, the other feature that I would use is that if there's a pneumothorax, then the feature that we are sharing or that is expected is that lucency outside or in the periphery of in the border of the lung. The reason why I don't think is or an argument against is that border is very undulating. So if it's a pneumothorax, the border of the lung against that area in the pleural space is usually a very well defined. So those would be my arguments. I can see the line. I know that it's abnormal. I like your thinking, well, it could be pneumothorax. I like you going to the upper check and saying, I don't see the pneumothorax. I actually see effusion. And then I will probably add these two more arguments to that discussion. So we are left with, there is an abnormal line. Probably we still need to figure out exactly where it belongs. Okay, anything else?
Can I just ask a question there? You mentioned before that another reason it shouldn't be a pneumothorax is because you have got soft tissue lateral to it. Can you point out on those x-rays where you're saying you've got soft tissue external to where with?
Cool.
I can't see it.
I don't remember now who was that pointed out that there is pleural effusion. Who was the one pointing out pleural effusion? Some of you
might have been me.
Okay, so I can probably show you. Probably I should have asked everyone. So this is a small finding, but I believe very relevant. So that's the border of the lung. The border of the lung, and I'm making it large because it's small finding, but it's there. So that border should be against the rib, okay? And then there is a widening of that space, probably even here. And then there is a soft tissue that goes around the lung. So this is kind of and then probably here, that's the classic pleural effusion line, makes sense? So we know, you may think, well, this guy is just picking lines, I will never be able to pick them. The reason why, the reason why we feel confident about that line is because we know where they sit. Makes sense? So anatomically, like you will not find a pleural effusion line here, because there is no lung lobes, there is no border of the lobe there. So those are in a pretty fixed place. So then we can, if we see a line that coincides with this kind of border like that, separation of the lung from the wall, and then kind of this rounding of the contour of the lung, and then from there is a pleural line taking off, then we are a lot more confident. So that is on this side. On this side is probably a bit harder, but I would probably argue that that's a pleural line, and I would probably argue that there is something wrong here. So that's a lower sign, and probably this is a normal lung against a slightly more normal lung. So we'll talk about that in a minute. So there is a mild amount of pleural effusion. And I remember, and I don't know why I haven't gone deeper on that, someone described this before. And that person that I saw, I can't remember who, argued that that is probably the reason why we couldn't see the diaphragm and the heart or the cardiac silhouette. And I would probably, even though we know that in theory pleural effusion, one of the imaging features of pleural effusion is silhouetting of the diaphragm and of the cardiac silhouette or border effacement. The amount of pleural effusion in this case probably is kind of a mismatch. That minimal amount of pleural effusion probably cannot justify the very severe effacement of the cardiac silhouette and the diaphragmatic contour. I don't know if you agree with that, but so we are putting, let's keep adding. Hopefully the thinking aloud is helping you first see the things, believe on what we are saying, and then also give you a different perspective about what we expect or not. I don't know. Yeah, we'll see. Okay, anything else? Okay.
Well, you can see lung patterns in that area there, so that to me suggests that the lung does extend its full extent, and there's air where the arrow is.
Mm-hmm. So you're saying that there are vessels that go through and they extend caudally or dorsally or beyond that border. Is that what you're saying?
Yeah, that's what I'm saying. And then the other thing is the lung here, to me, looks quite pathological.
Okay.
It's not an alveolar pattern hardly. It's a quite a severe interstitial pattern.
Okay. Can you show me that in the eye projection?
Good question.
Because I will be the devil's advocate, and then I would say, look, you are talking about an increase in the opacity there, So if you can show me that in the lateral projection, actually, just pleural effusion can result in a diffuse increase in the opacity. So how are we going to differentiate increased opacity within the lung from outside the lung? That's probably the challenge. Or what are the features that we're going to use to make the call about pleural effusion, and which are the features that we're going to use to make the call about lung disease? So I think we need to clarify this. Where exactly, someone has to put an argument about, I'm certain about the pleural effusion because of this, and I'm certain there is lung disease because of this. What's your hard evidence, let's say? Jeff, you were trying to defend the idea of lung disease, and I agree with you. This looks like there is lung disease, and you went even further and say, well, that's an interstitial or probably an alveolar. And I'm not disagreeing with you up to that point. I want you to bring hard evidence and to show me that those changes in the other projections, more than the right lateral. I want you to be able to find it in the DB projection.
Which is a good question, because you can't really see it in any other projection.
Okay, I'm not sure I agree, but okay, anyone else that wants to see if we can find that increased, I'm calling it increased opacity, until we find harder evidence to put it within the lung. I'm gonna just put it like that. And then we are trying to find evidence for that to be in the lung. Anyone willing to offer that evidence?
Well, I think you're looking for blood vessels. So I think if you can see blood vessels in the lung tissue, then you clearly haven't got a pleural effusion. And as Jeff says, you can see it in that area on the lateral, and that's what I'm looking for in the VD. I can see it on the left side. I can see blood vessels there. I can't see it as clearly in the right.
Excellent. That is excellent. That's it. That's the argument. That perfect. You put that in a frame, and that's it. That's exactly a point. So when you are looking for evidence of changes within the lung, and they are severe enough, the best way to look for those changes is to ask yourself, can I see vessels? And here I know that is difficult, but you've done just hit the nail in the head. Like, there is an asymmetry, so you can see vessels here, and it's the grape surrounded by gas. So the vessels on the left are soft tissue, and there is some air around those vessels, and that's why we see them. So they are here. And then even if there is pleural effusion, that should not change that, because the pleural effusion is outside. Now, if you go to the opposite, there is an increased opacity here, but it's not only that. We don't see the vessels. Makes sense? We see the airway, and that's perfectly fine. There is still gas within the airway, but it's a lot harder. See, all of these are vessels, and there's nothing on this side. Actually, what you see is airlongograms. Is the opposite. Is the black. So that is telling you that there is fluid around them, and it's not fluid there may be fluid in the pleural space, but not only that, because fluid in the pleural space, like in this case, in this left hemithorax, can easily explain why we don't see the body of the diaphragm or why we don't see the body of the heart, but it cannot explain, or if you come to this side, that separation, pleural effusion can explain that, but it cannot explain why we don't see the lung vessels. We don't see the lung vessels, so there has to be something next to them, and there has to be some fluid around them. So in this case, there is pleural effusion, mild. We see that separation. We see the pleural effusion lines. We see the silhouetting of the cardiac silhouette and diaphragm. And then on this side, on the right side, then we see similar findings. But in addition to that, there's an increase in lung opacity. And I think now we are in a position to say, well, this is likely to be that. Why it has that border, I don't know. But then at least we have hard evidence why there's not only pleural effusion, again, I insist, it's mild. Here we have that pleural effusion line, very thin. Makes sense? So not in that game and trying to localize the disease. In this case, there is pleural effusion, but I don't think you're gonna fix this dog by removing the pleural effusion because it's mild. The idea of finding that effusion is more than anything diagnostic, and the dyspnea of the dog is not explained by just because it's so mild. Okay. Are we all okay with that? Do you see? It's a challenging case. It looks clearly abnormal, but it's kind of tough to start getting on all the features and trying to localize abnormalities. There is more. So anyone bring more? Anyone? First, do you agree? Do you have a comment? Do you have a question? And then if not, or just anything else?
Any other thing I'm just struggling with is if this is mostly on the right side of the thorax, and you've got laterals with a right side down, and it actually looks, the lung looks more affected on the right lateral, which you actually should be looking at the left lung. And the left lateral doesn't look as bad, and yet we're looking at the right lung. So I haven't got my head around that. I don't know whether you can help.
I don't think I can help, and I agree with you. there is a little bit of a mismatch. I still believe, so what I would do is come here and say, is this radiograph okay? Is it mislabeled? So I would go and try to find the spleen, stomach. So this is correct. So yeah, the lung changes seems to be, I think there are lung changes in the left, but they are less severe compared to the right. So in theory, like a right lateral should look better than a left lateral. And arguably, they look almost the same. Probably there is more gas here on the right, yeah, compared to that. Makes sense. So here, if that's a border of the heart, it's very, 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 very hard. But probably the right looks slightly better than the left here. At least this low.
Yeah, okay.
But I agree. So I'm not sure I know how to explain that. I love that you're trying to put things together and try to, go from one projection to the other and have an expectation. And then if you can't fulfill the expectation, then you need to find a solution. That's perfect thinking. I would say that probably we have enough changes, both sides. And that would be the way that I have to explain why both lateral look so abnormal. But yeah, I see what you mean, and I don't have a clear explanation.
Okay, thank you.
Anything else? So until now we haven't touched the topic of, if we need to define the lung changes, we talk about interstitial and alveolar, and I completely agree with that. Another way to put this is very diffuse and generalized. Makes sense? So it's not focal, it's not multifocal. We are not talking about METs. We are not talking about a lung mass. The lung is clearly abnormal, but it's diffuse and generalized. And the pattern, if you want to pick a pattern, then it's going to be interstitial and alveolar. And then as a summary, there are superficial lines, mild separation of the lung from the wall, silhouetting of the, or effacement of the cardiac silhouette and diaphragm. That could be either because of the lung disease or perfusion. That could be kind of a summary of what we have. There is one more finding that I think is very relevant. Anything else that you want to add?
I don't know if it's just on my phone, but the abdominal detail doesn't look quite as it should. So maybe there's some some fluid in the abdomen.
Okay, I think that's a beautiful consideration, and we certainly need to look carefully for that, because then probably the list of diseases that we are going to consider kind of changes a bit if we have bicavitary effusion. Do we all agree with that comment, that there may be loss of serosal detail? I have a little bit of an argument, but I don't want to be the one always arguing.
There is some loss of detail, but when you look at the laterals, you can see that I think there must be very little fat, because it's not defined, but certainly the gas in the intestine and where is it? I'll have to just annotate that. You can, when you enlarge it up, you can see serosal detail there. It's not so obvious in the smaller one. You've got to enlarge it right up.
So from all of those comments, I think it's awesome for us to think about that. Then I also like the comment about, well, this is a thin dog. So then, that assessment, you need to really be careful about it. And I agree with that. I'll be really careful because, it's a very thin dog. And then I think there's still detail. And then we get into the very gray area. So, and there, I don't think anyone can be right or wrong, but as long as you decide, well, all of the features that we were talking about in the thorax are very clear. They were so clear that we even had a hard time deciding, what they were, because everything looks so abnormal. In the abdomen, okay, I'm not 100% sure, but whatever is happening there is, if it's something, it's going to be a mild amount. I'll probably think that it's okay. But I understand that there may be a gray area where we could be wrong, and the reason being that first of all the animal is very thin. So then that should be, we should consider that. Anything else? There's one more finding. So do you remember when we were talking about lesion localization? So if in this particular case, so if we go in order, so the wall seems to be okay. At least the part that we see from the wall, the ribs are okay. The distance in between the ribs, the opacity of the ribs are okay. We don't see any extrapleural sign, nothing coming from the wall, pushing the lung in. There's just that what we believe is pleural effusion. It's not focal, it's just diffuse the pleural lines. We don't see what's happening with the diaphragm, but there's no evidence of mass effect. So kind of we kind of know how to explain that inability to see the border of the diaphragm, but then we are okay with the wall. Then we go into a pleural space, and then we identify separation of the lung, pleural fissure line, silhouetting, all of those features of pleural effusion. Then we went in the lung, and then we decided there is an increase in the lung opacity. We went further and we decided, well, there is even interstitial alveolar pattern. Then the next point is, what do you think about the mediastinum?
Yeah, I'm just looking up here. You get you get a clear line of gas in the right cranial lobe, and I think it just outlines where the lobe is, and it makes it look like the mediastinum might be wider than it should be, perhaps up here. Because there's not that much pleural effusion that the cranial extent of the lungs should be, moved away from their normal extent, I think.
Awesome. So another phrase, another sentence to put in our frame, perfect argument. Now, and I completely agree with your lines that I would agree how to describe that. That's a widening of the mediastinum. Then we need to go further because that there are other things that we need to consider. So anything else I want to add to that? I don't want to start talking again. I completely agree. Your argument about why that is unlikely pleural effusion, because pleural effusion can be another reason why the lung. So there is not only widening of the mediastinum, there is caudal displacement of the lung. So the lung should go to the first rib. Now that widening of the mediastinum is so severe that now the cranial lung loss cannot go to the first rib. Perfect argument. Is there anything else that you want to tell me about that mediastinum? So the description is perfect. The argument is perfect. Probably what we need to be thinking is, what are the differentials? What are you thinking? How can you explain that feature? And then if you go that way, you realize that you need to look at some other things to paint a very nice picture of what's going on in the mediastinum. So one is the widening, perfectly understand, perfectly described, then even supported by the displacement of the lung, not only laterally but caudally, so perfect. Is there anything else that you want to describe about the mediastinum?
Well, the trachea is on the laterals. The trachea is not displaced. So
Excellent. Excellent.
Like a ventral or a ventral mass effect. So potentially it's fluid in the mediastinum rather than a mass.
Beautiful. Excellent. That's the thinking. Widening in one projection. If you see in one projection, at least you say, well, the trachea is not displaced on one side or the other. However, it could be displaced dorsally or ventrally. So then you need to come here and say, well, is the trachea displaced? Well, no, it is not displaced. So that whatever is happening in that mediastinum is acting, is displacing the lung, but it's not displacing the trachea. So it's not really acting a lot like a mass. Some of the features are not the trachea at least. So then your consideration about that being fluid rather than a mass, I think is perfect. I would have an additional hypothesis or way to explain that, which would be the most common situation to have a widening of the mediastinum. And it would be a very fat dog. The classic case would be a bulldog. So bulldog, fat, now the mediastinum is very wide and it's just fat deposition. So radiographically, you know, how you need to consider that option. And then again, we go and say, well, is this a fat dog? And now some people go and say, well, you need to compare with the sub-Q kind of at this level. Do you see a lot of sub-Q fat here? And the answer is no. So kind of, and this, you know, always working, but I think it's a very healthy way of thinking. So if there's not a lot of fat outside, it's unlikely to be a lot of fat inside. So then I agree with the widening the description, the argument why that cannot be pleural effusion. I very much agree with the argument why, or the absence of mass effect, at least related to the trachea. And then just warning you that anytime you see that, also consider the possibility of that being just accumulation of fat in the mediastinum. And I'm giving you the kind of the way out, or, you know, just check if there is a fat dog. Usually brachycephalic dogs, because of the conformation of the thorax, they tend to have a wider mediastinum. So in those cases, be more careful. In this particular case, that shape of the thorax and that finding in the mediastinum, I think is very clearly abnormal. So if we try to put everything together, now in the beginning, it looked clearly abnormal. It was very obvious that it was abnormal. Now, after half an hour, now we can be a lot more precise. We can say, well, we need to find an explanation for a disease that is affecting the lung with an interstitial alveolar pattern, diffuse and generalized, that also should explain pleural effusion and should also explain maybe fluid in the mediastinum. And that now we are ready to hypothesize. What could it be?
It could be hemorrhage, could be coagulopathy. It's probably not cardiac origin because the fluid is in the mediastinum.
So for the cardiac situation, I will probably argue that unless it's failing in the right and the left, then we don't expect this combination of findings.
Yeah, don't expect.
And then if it's failing on the, you know, so you could think about the lung changes secondary to failure on the left, but then the liver is not enlarged. There's, you know, not very clear fluid in the abdomen. So then to explain the pleural effusion secondary to right-sided failure, I think is a real stretch. And then we cannot explain the mediastinal changes. But so this is the exercise, you know, we put a hypothesis and we test, you know, how well it fits. In this case, I was trying to say, well, one feature fits, the other two features don't fit. So any other hypothesis? I really like the coagulopathy hypothesis because, you know, how many of the features can we explain?
I suspect he's got pneumonia. I think it's an infectious thing, but I don't know. I'm trying very hard to work out how that is associated with the mediastinum enlarging, unless there's a rupture, maybe an esophageal perforation, but I think there'd be other signs if it was. So the lung pattern to me looks like pneumonia. I think I'd leave it there.
Cool. So then based on the lung pattern, then you are, because it looks so much like pneumonia, yeah, so pneumonia could probably explain the lung changes, but then we are left with the pleural changes that is in dogs and in cats, different from, I think, cows or horses. One of them has more, I think it's the horse, where pleural pneumonia is a lot more common. In dogs and cats, it's very uncommon. So, and then we cannot explain the mediastinum, as you mentioned. And then the other thing that I would argue is that even the lung changes are not ventrally distributed. And probably the most severe one is the most dorsally distributed. So that doesn't really fit either. So we really need to push that. There are many, I always think about, those games where you have like a hole with different shapes, and then you have different things that if it's rounded or a cylinder, you put it and it fits perfectly, or if it's a square, you put it. So the pneumonia in the hole that we have really doesn't fit with pneumonia. We need to really push it very, very hard. It doesn't want to go in. Okay, any other hypothesis?
The other one, but a bit like Jeff, I actually don't, well, I don't think this is correct, but you can have a lung lobe torsion, and that can certainly cause, you can get an alveolar pattern and an interstitial pattern, and you can get pleural effusion, but that should happen more cranial. It usually happens on the right, doesn't it? But it's the right medial lobe, I think, is the one. I'm not sure about that. There's one of the right lobes that's more commonly tors, but I think you're seeing problems further caudally, so I'm not sure that fits either.
Okay, perfectly. So the argument there, I think you just hit the nail in the head. I would probably add that it's not only that there are certain lobes that are more commonly affected when there is a torsion, but also that there is a lobar thing. Makes sense? So it's just one lobe that is severely affected, and then the fusion, but then the rest of the lobes usually stay okay. And then there are additional findings or changes that we expect, which are, rotation of the trachea, and then the vesicular pattern in that affected lobe. So again, it's probably a better fitting compared to pneumonia, but still there are some things that don't perfectly fit. Probably you don't want to remove this completely away or out of the list, because it can explain two of the findings. It could explain the effusion and the lung changes, but the lung changes are not a perfect fit. There are some things that are not there that we expect, which is the rotation of the trachea and the abnormal appearance of the bronchi. And then probably we cannot explain the changes in the mediastinum. So 50% of the things fit, maybe 50% don't. To clarify, it's usually the right middle lung lobe or the cranial subsegment of the left cranial, depending on if a brachycephalic dog or a deep-chested dog.
It's right, isn't it?
The brachycephalic dogs are the left cranial, and the more deep-chested dogs is the right middle.
Okay. Yeah.
So perfect, but that's actually the exercise. We bring one disease, and the more this is, I think it needs a change in approach. The more creative you are now, makes sense. The more weird things. So this is an exercise where there is really no right or wrong. It's a fitting exercise. Makes sense. You bring as many ideas as possible, and you don't feel stupid if the idea doesn't fit. Makes sense. You say, this is exactly the exercise. So this is the part where you shouldn't be shy. I say, well, I'm not going to mention that because obviously, no. This is the time where you benefit from creative. You benefit from people bringing weird. So if it doesn't fit, you just throw it away. Makes sense. This is good because you can explain one of the features, but no, because many of the others we cannot explain. So this is the time where, again, if you are creative, if you don't care about being wrong, you're gonna be closer to what can go wrong is that you don't think about too many options. Makes sense? And that's the problem. The problem is not thinking about too many options. If you are, and that's where, for example, if I run out of options, I usually open the book. And probably open the book not because I forgot about how things look like, but as a way to trigger new hypotheses. Makes sense to say, well, the book is saying it could be this, and this, and this. And then I do hypothesis testing trigger by the list of things that I kind of forgot. Makes sense? But the exercise here is to bring as many as possible, and not to be shy in bringing them, and not to be shy in saying, well, it doesn't really fit. I just chuck it. Okay. Probably the other one that I would mention is neoplasia. Can we have a diffuse neoplasia? Can we have lymphoma that can explain the perfusion, the diffuse lung changes? Can it be something in the mediastinum looking like a big lymph node? I don't know. I will keep that in the list. And then probably because of the lung changes so diffuse, I think we need to include the differential of contusion, like trauma that we there is nothing in the wall, so that doesn't fit. But could it be trauma? Could it be hemothorax? Could it be bleeding in the mediastinum? Well, that fits with trauma. What it doesn't fit is there is no history of trauma, nothing in the wall. Could it be a non-cardiogenic edema, for example? And I think it could fit. What it doesn't fit is the pleural changes and the mediastinal changes. So that's kind of the exercise that you go through. So if we take the best fit, in my eyes, the best fit is one of the that you mentioned, like a coagulopathy. Coagulopathy can explain all of them. So then for that, so this is a coagulopathy. This is rodenticide toxicity. And I went through the paper, and basically there is one feature that is very characteristic, and unfortunately it is, or fortunately for the dog, but it's not present in this case, which is when there is coagulopathy, there could be narrowing of the lumen of the trachea. And that is because there is thickening of the wall. There is bleeding in the wall of the trachea. And then that's a very characteristic appearance. I don't think it's present in this case. But then other than that, then these are the findings, and this is the papers if you want to go and read it. And the way that I pack this information in my mind is that I should always think about a coagulopathy if I have an rodenticide in particular, if there is it's the three components affected: pleural, lung, and mediastinum. That's how I pack that information in my mind, and I remember it. Is if I find those three affected, I mean, it's not that it has to be only a coagulopathy, but you should consider that option. And the paper kind of supports that. So it's either increased mediastinal soft tissue opacity, the change in the trachea that is not that common, but if you see, then there are not too many things causing that. Various variable degrees of pleural effusion, generalized patchy interstitial alveolar pulmonary infiltrates. So this is a, the one that we got is a nice case, has all of the features. And we went through the possible differentials and the feeding or not feeding. Coming back to this line, I think that's the bordering between affected and unaffected lung. I don't know why it looks so much like this. It looks very weird, and I don't know. But coming back to here, I think this is the lung. I think that border is the border of the lung. There's no pneumothorax, there's pleural effusion. So I think it's just bleeding that that goes in the lung, and it's kind of I don't know why that border.
Do you
out of
know,
everything,
Mariano, it's interesting there's hemorrhage from sort of 3 different areas in the thorax, but not really a lot in the abdomen. Is that common that it's just thorax and not abdomen?
well, that's so probably we should ask a medicine person, but that's what I remember from the paper. And I don't know if they assess the abdomen, but that's also what I remember from real life, like cases like this. Yes, and I don't know why. I don't know if it's the motion, that produces enough, like that motion is enough trauma, or the negative pressure. I have no idea why. But yeah, the ones I remember are like this. So probably that's a good question for a medicine person. Yeah.
My experience with them has been that you can get bleeding anywhere, but not necessarily everywhere. You could get it in the joints. Lungs are a common place to see it. I remember one case that came in, I was nearly ready to, it came in because of a cough. I was nearly ready to put it off as a kennel cough when the owner happened to mention there was some blood in it. I thought, oh, better check the coagulation factors, and that's what it was. But the other thing about it is about the 9th day, I found that when they actually start to bleed, they'll be dead on the 10th if you don't transfuse them. But that's only just personal experience. They seem to just bleed a little bit and then crash, as it were. But when I was in Wagga, we saw more bleeding rat mates in a day than I had seen in 40 years during the mouse plague.
Yeah.
I'm trying to decide if this I think this case is from Sydney. Yeah. Yes, it is. It is. Yeah. So coming back to that comment about they could bleed, they can bleed anywhere, but not necessarily everywhere. I agree with that. So there may be many cases that we don't think about toxicity. If we see lung changes and pleural changes, we think about other things. For me, the flag, the warning flag, and probably I should be considering, even if in cases where it's not there, is the change in the mediastinum and the combination. There are not too many causes of fluid in the mediastinum looking like this. There are many causes of masses, and then but the trachea is displaced and everything. This association of findings, at least I decided to put in my mind and always think about this option. And I'm not sure how many other diseases. We went through some of them. Have this combination of findings. The association of findings, I think, is key. And also, obviously, going back then to the dog, Okay. Any other questions? That's the paper. It's always doing when I was trying to train people. I always, because it works for me, I always, sometimes we have the activities that we do in the clinic, at least in a residency, and then we have one day, whatever, we do book reading or journal club, and sometimes it's kind of separated from, what we do every day, because whatever comes in that journal, that issue, we may not have seen in the clinic, or maybe something. I remember pushing for the idea of, okay, let's, for that systematic study, you study, let's go through papers based on what we see in the clinic. Makes sense? Let's take the clinic and what we see in the clinic, and then feed that curiosity, and then go to the paper from there. And it's a very disorganized way, because different things show up in the clinic, but I think it's a more meaningful way. And then that still meets the systematic approach, but that is more for someone sitting down and studying systematic at home. In a clinical setting, I really enjoy this topic. Makes sense? You pick a topic, probably the trigger is something in the clinic, you pick a topic, you put a bunch of papers together, and then you go deep into that topic, rather than going from, more in imaging. You can go from CT of a horse, or MRI of this, and then those kind of journal clubs or situations get very, in my eyes, meaningless almost. Makes sense? Because there's so much information, so separated, so out of context, that putting things in context, that's the way I work better like that. Okay. Anyway.
It's good.
I agree.
Interesting one.
Yeah, and you've done. I'm so happy compared to like a year ago. Like I put a case like this, you are shy like for 5 minutes just because you're looking at the images, and then you just bring very, very relevant findings and very good arguments about what you think. I think that's the way. And then I love that you're not shy in bringing hypotheses, and that for me, once you get in that thing, then the only way forward is to keep on adding. Makes sense? Because I think you put the correct ingredients. You kind of identify things. You know how to play the game. You know how to bring hypotheses, how to test them. You're not shy about that. I love that. It's kind of working a lot better than a year ago.
I think we're all learning that it's okay to be wrong, because you still learn from being wrong as well.
Definitely.
Yes.
Oh, well, if you are so, and I suppose in different activities, the price to pay if you are wrong is very high. So you need to be really, really careful. In imaging, I think you will get things but it's not really being wrong. It's playful. I don't know. If someone is listening to me and says, this guy is crazy, and I don't care. I think there is an attitude of the hypothesis testing, just putting ideas and then not being shy about saying, well, no, that was a bad idea. I drop it. But that, and then that also brings an attitude about listening to someone else. They always good ideas, or you just consider it and then in a very nice and thoughtful and justified way, you say, well, I disagree with you because of this, this, and this. It's not personal. It's that you put an idea. I put also my ideas, and I also challenge my ideas. And then after challenging your idea or my idea, I think if we need to look for another explanation. Make sense? So
Yeah, good.
that's what I like. So about imaging. Yeah.
Yeah.
And there is room for that. And actually, you are going to be good if you can do that, I suppose. Anyway,
Excellent.
now we work.
Yeah.
Thank you, Mariano.
Yeah,
Thanks,
Yeah,
Marianne.
thanks.
yeah, the fun's over. Thanks,
Thank you.
Mariano.
Thanks,
Well, still
Marianne.
next
Yeah.
week.